All right, thank you very much. As you mentioned, I was stationed in Baghdad, Iraq. I have a fellowship training in acute pain medicine and regional anesthesia, and that's really going to direct a majority of my talk, and I'm going to talk mainly about what we're doing now on the battlefield for acute pain before the patients are getting to more advanced regional anesthetic techniques or more intense analgesic modalities. Before I begin, I would like to declare that I have no conflicts of interest, no financial incentives with this. And in addition to these four goals, what I really want to pass on is kind of what we're doing using current modes of analgesia to improve pain and improve outcomes with a particular focus on sparing opioids. In addition, since I happen to have an audience of experts, by the end of this presentation, I'll come around and kind of pass out my contact information. If you have any ideas for directions for research, we're always open to thoughts from your own experiences. All right, so common acronym in the military, bottom line up front. True story, when someone's injured on the battlefield, me as a pain physician, I don't play a majority of the role early on. This is going to be the physician extenders, this is going to be the combat medics, the Navy corpsmen, this is going to be individuals who are next to that injured soldier or service member. This flow sheet, although it may seem slightly overwhelming, I just wanted to kind of give you an overview on everything that can possibly happen for pain control before the patient reaches a physician who's capable of more intense or more advanced analgesia techniques. And I'll come back to this slide. So a number of guidelines guide our therapy. We didn't just randomly pick certain interventions to test out. The main one, which is going to be discussed in a presentation following mine, is the Tactical Combat Casualty Care Guidelines. This is where we really educate our combat medics or even our soldiers in their basic tasks of taking care of their battle buddies, even if they're not particularly medically trained. We steal some guidelines or some ideas from the Wilderness Medicine Society's guidelines and their publications. And lastly, any of our physicians or physician extenders who are pushed beyond the quote-unquote hospital, the combat support hospital, they're going to be following the Joint Trauma Systems clinical practice guidelines, which do guide some analgesia therapy on the battlefield. All right, so the reason I have this particular slide up is kind of to display a concept that's very unique to the military. One of the things we are special at is being able to provide care to someone who's wounded in the middle of nowhere on the other side of the world. But it relies on a very specific system, which is different than the civilian entities have. And what I want to point out is our soldiers or our service members are really not going to be exposed to advanced pain interventions until they reach that Role 3, the Combat Support Hospital, which is typically a tented facility. Some more recent modifications have allowed us to take hold in some fixed structures, but really this is, up until this point, we're going to rely on pre-hospital care. All right, so in our pre-hospital providers, they need to be trained in some of the same things we are. And just like we do for pain, we need to assess before we treat. So they're taught the same way. They're taught to look for certain cues, to characterize pain, so that they can pass on this information to us. However, as I go through our modalities, you're going to find that most of our analgesic interventions on the battlefield are going to target acute nociceptive somatic pain. It's not that we ignore neuropathic, it's not that we ignore the visceral components to pain, it's that typically the heaviest burden of pain on the battlefield is somatic nociceptive. So we mentioned the Defense and Veterans Pain Rating Scale in the previous talk given by Colonel Griffith. So we find this scale very useful and very applicable in the combat environment, but not only that, we've started to actually see applications in the civilian era. This card is very special, very important to us, and I'll tell you why. The front of this card is pretty simple. With this system, basically we take this card to a patient and we go over the pain scale. It's simply a numeric rating scale on the front of the card, 0 to 10, with some verbal descriptors to provide some validity. But the really special part is when you flip the card over. It's very difficult when patients are in their most severe, most extreme form of pain to ask them to quantify their pain in terms of one number. And you guys may have seen this to be a challenge yourselves. Sometimes you'll ask patients who are trying to be stoic, and they'll tell you, well, I have a 2 out of 10 pain. But then when you ask their physical therapist how they're doing or read the note, they're not doing physical therapy, or When you talk to a family member, they're not sleeping because of pain. Well, this helps you guide therapy, and this gives you other cues on how to escalate therapy and how to direct therapy. On the reverse, what you probably run in contact with even more of is a patient who declares that they have a 14 out of 10 pain. One, that tells you that they misunderstand your scoring system, but two, the really helpful part is you can start to get them to focus on a particular aspect that pain is impacting their lives. So what we'll do is we'll sit down with these patients and we'll say, hey, on a scale of 1 to 10, how much does pain impact your mood or your activity? And usually we can come up with a more accurate method of targeting their pain. Sometimes, and more often than not, unnecessary escalations in analgesic therapy lead to harm as opposed to benefit, and this helps us avoid that. So our pre-hospital providers, after they've assessed for severity and character of pain, they complete the HPI so that they can kind of pass on some triggers to us so we can be ready at the combat support hospital, or if we're pushed forward, we're prepared to provide more advanced analgesic modalities. So now that we've assessed, we have to treat. So Colonel Griffith mentioned that when pain is at its most severe, we try to stick to a multimodal therapy, using 3 or more, often 5, 6 modes of therapy to really get on top of that pain control. Now, it does bring up the idea of polypharmacy, so we do have to watch out for causing delirium or causing other unwanted consequences. But why do we still stick to multimodal? Well, we do for 2 main reasons. One, when pain is at its absolute worst, it only makes sense that you should attack pain throughout the entire pathway, rather than just picking one step. The second is this gentleman on the right side of the screen, Paracelsus, he's known as the father of toxicology. He's famous for a statement he made where he said, "Only the dose determines the toxin." And we certainly find this true today. We're told when we're young, you drink some water. It's good for you. Drink more water. It's better for you. But we know at some point that water becomes toxic. And the same thing with our analgesic modalities. Yes, a little bit of Tylenol is going to help with pain. A lot of Tylenol is going to hurt your liver. A little bit of NSAIDs is going to do the same with your kidneys. But what if I give a little bit of each medication that's appropriate for your character of pain, but I don't allow it to reach that toxic threshold? So I don't allow that morphine to cause respiratory depression. I don't allow the regional anesthetic to cause local anesthetic toxicity. Well, now I have a good chance of tackling your pain while improving your outcome. So how do we pick these modalities? Well, for us, what was helpful was to take a step back, just look at the pain pathway, and go through each step and come up with ideas with how we can tackle current pain in the combat environment. So I'm not going to try to simplify this too much, but basically starting with transduction. Transduction, the state where as humans we take any form of energy that's going to be potentially or actually harmful to our tissues and convert it to an electrical signal. So during this is where we take our first step in the management pathway. As TCCC, or Tactical Combat Casualty Care, will ask of us, if you don't expect to obtain fire superiority in your environment, then you need to evacuate that patient to an area that they'll be safe. So first step is if the bullets are causing pain, stop the bullets. Secondly, you'll notice that there is our bodies have the ability to cause peripheral sensitization, to start the inflammatory soup, if you will, the cytokines, the local signals that are going to expand the pain at the immediate site of tissue damage or injury. And in this step, this is where we actually most of our soldiers that are in a combat environment, when they go out, they're going out with a pill pack on them that contains moxifloxacin, which is not going to help with pain too much, but then contains Tylenol and Mobic. And Mobic we've selected because it's a relatively cheap, COX-2 preferential NSAID that's not going to inhibit platelets and worsen bleeding on the battlefield too much. So we've already started our analgesic by simply having the medication on the soldier that as long as the GI tract is intact, we can administer. Or not we, but our pre-hospital providers. Transmission. So this is probably our most potent and impactful form of analgesia. This involves use of epidurals, intrathecal injections or intrathecal catheters, paravertebrals, fascial plane blocks, selective nerve blocks, brachial plexus or the plexus injections. This is where we're able to provide the most intense pain relief without impacting the patient in a systemic manner. So we are very aggressive with this. One of the things that tells us as a military, why do we need to push our providers forward, or in some instances, why do we need to teach physician extenders to be able to provide some of these more advanced techniques that carry some risk with just performing the techniques? Well, it's because there's some major benefit to the timing of these interventions. There are many studies, but I picked this one because for me it's the most simple to understand. In 2003, published in Anesthesiology, what we found was that early as opposed to late epidurals placed in patients undergoing a hysterectomy, long after the epidural has been discontinued, patients who had the early regional anesthetic had lower pain scores. What's even more interesting is days after, if you measure inflammatory state by surrogates, biomarkers, this is one of the new popular things, looking at interleukins, looking at tumor necrosis factors, we find that these are elevated in patients who had the delayed regional anesthetic. So that tells us there's a dying need, there's an intense need to push providers out early, because not only are we going to improve pain, but we're going to improve outcomes in general. Next step in the pain pathway is modulation. There's really not all that much to talk about here, as in a following presentation I'm going to touch on it a little bit, but opioids have their roles, and I don't need to speak to you anymore about the utility of opioids in acute pain, but we have a heavy reliance on ketamine use, and I'll get into some of the benefits of ketamine, but of our pre-hospital providers, if they're treating a patient, there is I would say of all the medications, ketamine is used the most at a current rate of about 57% on the battlefield. It has many benefits that I'll touch on later that are very applicable to the combat environment. So last step of the pain pathway is perception. And here I'm going to get into what we do with perception, but we know perception is real on the battlefield. We know it is because there are therapies that take advantage of it. There are pathologies that require perception or cortical mapping is an implicator in the pain pathway. So touching on perception, you're going to see that although it's the last step in the pain pathway, it's going to be one of the things that we touch on first. Comfort care is the first thing that we apply, and though it seems simple, it seems meaningless, but believe it or not, these steps, if you follow them correctly, they spare opioids. And many of you in your clinic, you find this to be true. Basically, you sit down, talk to the patient, address the patient by their preferred name. Now the patient understands that their problems are your problems as well. You inform the patient that there's a plan we're going to follow. We may not fix your pain to 0 out of 10, and in fact, we'll probably cause more harm than good if we bring you to 0 out of 10 pain. But we want to control it so we can improve your lifestyle, so that you can sleep, you can spend time with family, you can do your own activities of daily living. And this is how you're going to recover. And then eventually, we get to the point where if improvements are needed, we can get there. But I am going to help you. Lastly, you tell the patient that here's our system, I'm going to be your doc, I'm going to be performing your interventional procedures, here's your medic, here's your nurse. We'll always be around. Contact us if you need. Obviously, this is slightly different than the civilian world, but as long as they know there's a plan in place and that you are going to be there, believe it or not, that actually has been proven to reduce opioid consumption and pain scores. Then price therapy. This is the part where we accept the fact that our pain is a useful part to the recovery process, but pain itself can become pathologic. Inflammation can become pathologic. So to an extent that both the injuries or the dressings or the patient allow, we apply price therapy. And then the pharmacologic plan, I want to give you some evidence to why we do what we do. So I told you about the pill pack containing NSAIDs and Mobic early on. Why do we provide that? I mean, it seems like if you get blown up, it's the last thing that's going to help. Well, it turns out if we give both NSAIDs and Tylenol, they are going to spare opioids. They are going to improve pain scores. And to some extent, they're going to improve outcomes. NSAIDs are much more potent at this than acetaminophen is, but they come at a cost. You have to worry about things like bone healing. You have to worry about things like bleeding, gastric ulcers, acute kidney injury. But in the context, they can be very, very helpful. And Mobic and Celebrex do tend to be, celecoxib and meloxicam tend to be very, very helpful for us in the combat environment. Gabapentinoids, I'm not going to have too much time to touch on them, so I'll speed through this part. Gabapentinoids do not get routinely administered on the battlefield because gabapentinoids do come at a cost. They need to be administered to select patients, we're talking neuropathic pain or very high opioid consumption, to really see their benefit. and they're associated with a transient cognitive deficit that can be harmful on the battlefield. And much like your benzodiazepines, they can cause hypoxemia when combined with opioids. So I mentioned ketamine. So ketamine and some other adjuncts we have really pushed to include in the combat environment. Looking at ketamine, I mentioned I'd discuss a little bit more. So ketamine is not a potent respiratory depressant. Ketamine does not cause hemodynamic instability unless you have some compromised catechol release or you have a patient who's catechol depleted. Ketamine is going to improve pain in the immediate period. It's going to treat both nociceptive and neuropathic pain. And turns out that there's a chance that it's going to improve pain long after its context-sensitive half-time. So there are benefits later to using ketamine earlier. When a regional anesthetic cannot be applied, it's appropriate to consider use of systemic local anesthesia. It's not going to be as good as most of your appropriately applied regional anesthetics, but it's a tool. Precedex is going to be just as good, clonidine as well. The big benefits with these is these are going to act somewhat like ketamine in that they're going to improve your long-term pain outcomes. The other thing I'd like to touch on is we've started to use Precedex and clonidine heavily in our perineural blocks. You tend to see a more intense analgesia. You also, this is a rat study, so I'm not going to say that this is completely applicable to humans, but there's a theoretic neuroprotective benefit to alpha-2 agonists. So more to come on that, but there's enough benefits that we do use it perineurally. So regional anesthesia. This is really the lightsaber, if any of you are Star Wars fans of us on the battlefield, because it's your most intense form of analgesia, but we're going to improve mortality. In specific patient populations, there's data to say you are more likely to live in the perioperative period if you had a regional anesthetic. Obviously, these are specific patient populations, but we know benefits. We know there's a reduction in blood loss in specific procedures. There's a reduction in pneumonias, a reduction in DVTs, multiple benefits. And for outcomes less intensity, but still of importance, musculoskeletal function, bowel motility, end organ perfusion, these are all benefited by regional anesthetics. So we push for them in a very aggressive manner. In addition, we are finding that as we move our surgical assets around the battlefield very quickly, we've had to modify some of our application of general anesthetics. And this is one of the reasons why regional anesthesia has taken hold in such a promising way in battlefield pain management. Because we need to be so mobile, we've lost some of the ability to use large ventilators and anesthesia machines. Our ability to use volatile anesthetics is even limited. So you're seeing a lot of total intravenous anesthesia. You're seeing a lot of manual ventilation where you can't haul around a ventilator. We do have portable ventilators. You're seeing heavy reliance on adjuncts, systemic adjuncts like ketamine, Precedex, propofol infusions, because we do need to maintain some mobility on the battlefield. Again, back to our flow sheet. I wanted the chance to go through it because it's massive. But for our pre-hospital providers, this is what we're kind of asking. So first, when a patient comes in, a wounded service member comes in, comfort care and price therapy is going to be applied immediately. That pill pack, if it hasn't already been given, then we have an algorithm for how we can most appropriately select an NSAID that's going to provide the most appropriate or most effective analgesia. Then, if possible, we consider a regional anesthetic. So things like bleeding, local infection site, patient refusal, concern for compartment syndrome of an extremity. These are things that may contraindicate use of regional anesthetics, but if it's safe, we, as I mentioned, want to apply it early and often. Then moving down to at the bottom of the screen, you'll see this complex branching is what our medics know to go through for how to apply their modulation therapies, how to apply their ketamine, how to apply their opioids with or without IVs, and dependent on whether or not the patient is hemodynamically stable or at risk for respiratory compromise. I only have 32 seconds left, so I'm not going to go through my case report unless we have time at the end. But here are my references. Do you all have any questions? All right.